Good afternoon, everybody. This is Michelle Hughes with NC Child, and we are going to go ahead and get started with the webinar. So I want to thank everybody for being part of this next hour where we do a Medicaid Transformation kind of 101. We know that there's lots of questions about Medicaid, managed care, lots of acronyms. There's PHPs and PLEs and EPSDT, and so we are hoping to spend the next hour just talking a little bit about the foundation of Medicaid, why it's such an important program for kids, and then a little bit about what's happening with managed care and that process in North Carolina, and what advocates across the state, what kind of questions we're asking, and what we're looking out for kids. So we are going to, here are your two presenters. If I can get my computer to work. Rob has to help me get my computer to work, apparently. So I'm Michelle Hughes. I'm the Executive Director of NC Child, and I'm here with Rob Thompson, our Deputy Director, and we are going to tag team this presentation today. I'm going to talk a little bit about the foundation of Medicaid. Rob's going to kind of talk more about the benefits of the Medicaid program for kids, and then talk a little bit about what's happening with managed care. So the goal today is really to kind of not dive too much into the weeds of Medicaid and managed care, but really to provide a high-level overview of North Carolina's Medicaid program and what folks are calling Medicaid Transformation. As we move from a fee-for-service program into a managed care program, what does that look like in North Carolina, and what are the potential impacts on children? Couple logistics is that we are going to be on the phone for about an hour, in this webinar about an hour. We have everybody muted because the feedback sometimes can be really disruptive. So if you have a question, go ahead and use your Q&A for questions. We're going to try to leave time at the end to answer some. If there are questions that we don't have the answers to, because Medicaid can be a complex thing, we promise to get the answers to that. And also, we are open to having an additional webinar with experts who can provide more specific information about particular things that folks are interested in discussing. So today's agenda is sort of divided into two different pieces. The first part is about what is Medicaid and why it's important for children. It's hard to talk about managed care without sort of a foundation of understanding what is Medicaid, what kind of benefits and services it provides, who is enrolled in the program, and what are the impacts of the program. Then Rob is going to talk more about sort of managed care. What is it? What's the plan in North Carolina? What's the ever-changing timeline? And what are some of the things that we are concerned about? So we're going to do a little infomercial before we dive into Medicaid, just a little bit about NC Child. Many of you are Child Advocacy Network members, so you know who we are and the work that we do. But for those of you that don't know us or aren't as familiar, NC Child is a policy advocacy organization for kids. Our mission is to build a stronger North Carolina by advancing public policies, both at the state and federal and local levels, to ensure that all children, regardless of their race, ethnicity, or their place of birth, have the opportunity to achieve their full potential. We focus on 5 different policy areas that we believe are super important to children thriving, and that when kids have good outcomes in these 5 areas, they are able to successfully transition into being productive and able and healthy adults. They need a strong start. They need to be born healthy and have health throughout their life. We want kids to be growing up in nurturing homes and communities, grow up with families and communities that have economic security, and that they have high access to high quality education. And we achieve public policy by combining 4 different strategies. We are the Kids Count Data Center for North Carolina. So we have our about 100 different indicators of child well-being that we keep track of and provide out to communities and advocates to help inform their advocacy efforts. We do a lot of different strategic communications. You all probably get emails from us with our infonet, our blogs, our legislative updates. We do a lot of work with the press and social media. We also are down at the legislature, directly lobbying and working with policymakers, as well as with members of the administration and other elected officials. And then we have our Child Advocacy Network. which is a network of about 7,000 folks across the state who want to be voices for kids and who are interested in being part of the dialogue about what's important for kids at the state level and who are leaders in their own communities in terms of policy. And so we are excited to be working with folks like you who care about kids and who want to make sure that they have the best outcomes possible. So we're going to switch now and talk a little bit about what is Medicaid and why it is so important for children. So at the most basic level, Medicaid is a health insurance program that serves low-income children, adults, senior citizens, and people with disabilities. It's important for lots of different reasons, but one of the really important reasons is that it helps millions of Americans get health care and stay healthy by seeing the doctor when they're sick, getting checkups as needed, not postponing their health care, filling prescriptions, and going to the hospital when they need to without sort of the fear of choosing between their health and paying for their rent or their groceries. It is a really important financial support for so many Americans by providing them with the preventative care and treatment that they need in order to stay healthy, stay employed, stay in school, and be successful. Medicaid is a partnership, really, between the federal government and state government, North Carolina. It was enacted in 1965, along with Medicare, and participation in the Medicaid program is voluntary. States don't have to, but all states currently do and have been participating since 1982. The federal government shares part of the cost of Medicaid services that the state is paying for, and that can range anywhere between 50 and 75% of the cost for eligible individuals and services. And there's a lot of discretion in running the program. So although there's some federal guidelines and rules and regulations, states have a fair amount of discretion in how they run the programs on a day-to-day basis. For example, states have options about who to cover beyond the core mandated groups. And they can extend coverage to additional groups. A great example is, of course, Medicaid expansion, where many states have decided to extend Medicaid coverage to childless adults who are fall into the health insurance gap. And North Carolina is a state who has decided not to do that at this time, but we have the option to extend coverage to that group if we decided to. The legislature decided to. Other state decision points that states can have a lot of discretion is income eligibility, benefits, premiums, co-pays. States can provide a more generous Medicaid program in these different areas. And there's also, as we'll talk more and Rob will talk more about, states have a lot of discretion in terms of the delivery system. For example, moving from a fee-for-service delivery system, which we're currently in now, into a managed care system and how those services are paid for and delivered in the state. So all of this change or difference between states leads many folks who work in Medicaid to say, if you've seen one Medicaid program, you have seen one Medicaid program, because there's a lot of variety and difference between the states in terms of how they provide and pay for these services. What is consistent for Medicaid across the states are two commitments. One is to the states themselves. So for those states that are participating in Medicaid and paying for the health care services of folks who are eligible, there is an open-ended federal match. Medicaid is a federal program that is not capped. And so unlike other federal programs, block grants and other things, Medicaid is not capped. There is an open-ended federal match for what the states are paying for. There's also a commitment to eligible Americans, that there's a guarantee of health insurance for the covered services when they are medically necessary, and that there's no constraints in terms of waiting lists or time limits. And these two commitments are important because they're legally enforceable in federal court. States are bound by the state plan that we submit to the federal government in terms of implementing and administering those plans. A little bit about who is eligible for Medicaid and the different populations that are eligible in North Carolina. So what you'll see is a chart here of different categories of people, children and pregnant women, parents, etc. So for children 0 through 5 years old, this is based on income eligibility. Children who are living in families that are up to 215% of the federal poverty level are eligible for Medicaid. For children 6 to 18, they are eligible for Medicaid if their families are 138 up to 138% FPL. The CHIP program, the State Child Health Insurance Program, or Health Choice, covers that gap for about 111,000 children, that gray part of the chart, for those kids that are between 138 and 216 of the federal poverty level. Pregnant women are covered in North Carolina up to 201% of FPL. And for parents, you'll see that that's a very small, low percentage. And only parents who have children and who have just 43% of the federal poverty level. So these are parents who are in deep poverty, very poor parents, and there's very few parents that are covered under Medicaid because of this. All other adults are not covered, childless adults are not covered by Medicaid unless it's determined that they have a disability. And this, again, is where Medicaid expansion becomes an issue in terms of whether we would like to expand coverage to other adults who don't have insurance. In terms of who are the big populations that are enrolled in Medicaid, and then what are the expenditures, what you'll see on the left-hand side is that more than half of North Carolina enrollees are children. Adults are about 21%, disabled is about 18%, and the elderly, and this is mostly for nursing homes and other things, are about 9%, almost 10%. So even though children are the majority of enrollees, you will see on the right-hand side that they are their care is inexpensive. In terms of expenditures, services for children only really cover about 22% of expenditures. The vast majority of spending in Medicaid in terms of cost for services is for folks who have disabilities because that care can be costly and long-term. One of the things that's important when we think about managed care, and Rob will talk about this a little bit more, is that in terms of cost savings, one of the things child advocates are worried about is that there's not a whole lot of cost savings for children in terms of their care. Majority of kids are healthy, and there's not a lot of room for cutting costs. And so that's one of the things that we are watching out for. In terms of what Medicaid means for children, I want to talk a little bit about how important Medicaid is for kids and why we're so concerned about the transition into managed care and what that means for Medicaid. Medicaid, along with the Children's Health Insurance Program and the Affordable Care Act, are sort of three big drivers that have been driving sort of the decline in uninsured children, not only in North Carolina, but across the country. Medicaid is a huge driver. As you'll see, North Carolina, we are right sort of on par with the national rate of children who are uninsured. There are other states that are doing a little bit better than us. There's some other states that are doing worse, but we have seen a huge decline in children who have no insurance. And the next chart shows sort of this increase of children who have insurance. So in 2016, almost 96% of children, 95.5% had health insurance coverage. And again, that is because of the sort of three pillars of health insurance coverage for kids: Medicaid, the Children's Health Insurance Program, and the ACA have all contributed to that rise over the past 2 decades, which is a huge celebration and really a huge victory for kids that I really don't want to underestimate. When we look at those different programs that I just mentioned, those three pillars, you'll see that Medicaid is really the big pillar. more than 1.2 million children in North Carolina receive their health insurance through the Medicaid program. The Children's Health Insurance Program, or CHIP, is a super important program, just got reauthorized after a very big fight, but it's much smaller. It covers about 111,000 children, and then children who are receiving their care through the marketplace and premium subsidies is about 55,000, so much smaller. So Medicaid really is an enormous program in the sense that more than half of our kids, about half of our kids in North Carolina, are getting their health insurance through the Medicaid program. So physical health, behavioral health, oral health, their prescriptions, their vision, all of that is through Medicaid. And again, that is half of our kids in North Carolina. In terms of not only is it a huge number of kids that are getting their coverage through Medicaid, it's also some of our most vulnerable kids. So if you look at the left-hand side of this chart, you'll see that 82% of kids who are living in poverty or near poverty are getting their health insurance through Medicaid. For young children, infants and toddlers and preschoolers, again, about half of them are getting their insurance through Medicaid. Children with disabilities, very similar thing. And then for our children in foster care, and right now we have about more than 16,000 kids in foster care, we have about 100% of those children, all of those children, are getting their health insurance coverage and behavioral health through the Medicaid program. And half of our births in North Carolina are covered through the Medicaid program. So again, our most vulnerable children are getting an enormous support for their health and well-being through Medicaid. And we know from research that it's not just about health insurance, that the outcomes and the impacts of Medicaid are long-lasting and across multiple kind of child outcomes. We know from lots of research done on children who've been enrolled in Medicaid that children who have Medicaid miss fewer days of school due to injury or illness. They do better in school. They're more likely to graduate high school and attend college. They are more likely, even as adults, to be healthier, earn higher wages, and pay more taxes. And so Medicaid, in terms of the investment on the front end, certainly has a huge return on investment later on for kids, even into their adulthood. And I'm going to turn this over to Rob so he can talk about what kind of benefits Medicaid provides.
All right. Thank you, Michelle. One of these days, we are going to get to the managed care piece, but we've got to cover a few more things before we get there. So here are some of the benefits that Medicaid provides for kids, and this includes some services for adults too. So you can see it really is comprehensive health care. It includes everything from doctors to radiology, to specialized therapy, to prescriptions, vision, hearing, dental, podiatry. The list kind of goes on here. And some of the things that you might not even think of as being funded by Medicaid. So therapeutic foster care, for instance, is partially funded by Medicaid. So it really is has broad importance to a variety of things that are important for kids in North Carolina. Specifically, I want to talk about Medicaid's benefit for children, otherwise known as EPSDT. And I know we promised not too much alphabet soup for this webinar, but we've got to do a little bit of it. So it stands for Early Periodic Screening, Diagnostic, and Treatment Benefit. And what this really means, when you if you want to boil it down, is that children have a legal right to get the right service at the right time and the right place. It covers all medically necessary services, and even if those services aren't included in the state Medicaid plan. States are required to inform all Medicaid individuals and families under 21 that EPSDT services are available. So this is just, I can't stress enough what a core benefit this is for children on Medicaid. So here's a little bit more about the screening piece. So getting back to the alphabet soup, it's EPS. This is the EPS, Early and Periodic Screening. Medical screens, so health and developmental history, physical exam, immunizations, lab tests, including blood lead levels, which is extremely important, health education. That also includes vision, hearing, and dental. Then you get into the diagnosis and treatment. So it's not enough meeting the EPSDT benefit. It's not enough to just screen and find out about issues. The Medicaid program has an obligation to appropriately treat those issues. So all physical and mental illnesses or conditions discovered by any screening or diagnostic procedure must be treated, regardless of whether the health services for such treatment are otherwise covered under the Medicaid state plan. So that is, Michelle is whispering to me about a special resource that was recently put out by the Justice Center, who did a great EPSDT paper issue brief recently. And so we'll send that out to all of y'all so you can take a look at it after this call. Moving on. All right. As promised, Medicaid Transformation. So here's the agenda for this section. So what is managed care? What does it look like in North Carolina? What's our plan? What's the timeline? And why? What are we concerned about and why? So Michelle, in one of her early slides, talked about how states have a good amount of flexibility when it comes to implementing their Medicaid programs. And one of the big chunks or big areas of flexibility is in their care delivery systems. So ever since its inception, North Carolina's Medicaid program has been fee-for-service. And so what that means is that the state contracts directly with providers and pays them for covered services. So if I go to the doctor for my annual physical evaluation, they are going to have a specific code, and the provider is going to be paid a specific amount of money based on that code. Managed care is fundamentally different. So the state contracts with a third-party managed care organization to oversee delivery and payment of services. So the state provides these third-party MCOs with a lump sum of money and essentially tells them to go, within some parameters, provide care, not directly, but to oversee the delivery and payment of services to care for a specific population. So very different method of delivering care. And just for context, I think 43 states across the country now use managed care for most of their Medicaid enrollees. So I want to talk a little bit about effective managed care versus ineffective managed care, because there is an opportunity with managed care. So in a managed care system that's set up well and is effective, these managed care organizations, these third parties, are incentivized to provide effective preventive care and treatment of chronic conditions to cut down on expensive treatment. And as a result, population health outcomes improve. So if you're, the way this works, if you're a managed care company and you have a set of money, lump sum of money to spend, it is typically going to cost less to provide really high quality person-centered care early on in upstream services to prevent expensive treatments down the road. So that's lining up a good financial incentive with good population health outcomes. It can also cut a completely different way. So here's what ineffective managed care looks like. These managed care organizations are incentivized to deny needed treatments to make money. As a result, consumers don't get the care they need and population level health outcomes worsen. So in this case, rather than providing really good preventative care, they just, the MCOs start denying services that are needed. And by denying services, they're not paying for them, and that's another way to make money. So this is what bad managed care looks like, and this is what we want to avoid in North Carolina. And this is really the key tension in this care delivery system. If you look at what's happened in any other state, there's this kind of fundamental tension about making sure people, Medicaid recipients, get the care they need and the financial incentives of that system. So we put together a list here of things that we think constitute effective managed care and ineffective managed care systems. So just some characteristics that we can use to evaluate what our system is doing as we put it together. So effective managed care is closely regulated by a state agency. The contracts include very specific details about service and outcome requirements for MCOs. Data is accurately collected and shared with stakeholders in a timely manner. So this is so we, as advocates and others, can measure and see how patients within certain MCOs are doing. Are their health outcomes improving or worsening? Because really, in the end, that's what it's all about. Decision-making about service approval is transparent. So this is really important when MCOs are making decisions about what services are approved. That process needs to be transparent so consumers can have an understanding and appeal if necessary. There needs to be an independent ombudsman, which is going to be a part of North Carolina's plan. Profits need to be capped so that to ensure that MCOs are reinvesting some of the money they're making back into the health of the populations that they're serving. And there needs to be a robust provider network. We know that no matter if it doesn't matter if kids are insured, if there's not the providers in their counties or in their areas to provide the services. So ineffective managed care is largely the opposite of this. So I could kind of just sum that up with one word, but I'll go through it. So loosely regulated by a state agency. So we have an example of this recently where Cardinal Innovations, the leadership there really ran amok with irresponsible spending and not putting money back into the patient population. And what we saw happening was that people were being denied care that they really needed. Ineffective managed care, the contracts are ambiguous about service and outcome requirements. The data and decision-making are not transparent and they're inaccessible to consumers. There's not that adequate provider network. And in the end, needed services are denied and delayed for children and families in need. So one thing to note before I dive into the current plan for North Carolina, it's worth noting that we already do have managed care in North Carolina for our behavioral health system. I'm sure many of you are familiar with the LME MCOs, also known as local management entities, managed care organizations, and they administer our state's mental health care, both the state funded dollars and the Medicaid dollars in 7 geographically specific regions across the state. So this does already exist. And, you know, I say this just because it's important context, and also because part of the reason I think many of us have hesitations and concerns about this overall transition to managed care for both physical health as well, is that managed care for behavioral health has been a mixed bag. I think in some areas it's been better than others, but we've heard way too many stories across the state of consumers being denied care they need, and of providers simply drying up because it's impossible to work with some of the LME MCOs. So those are phenomena that we want to be mindful of as we move into this current transformation effort. All right. So here are some key facts about North Carolina's managed care transition. In 2015, the state legislature passed a bill requiring NCDHHS to transition North Carolina's Medicaid program from fee-for-service to managed care. The driving force behind this legislation was largely budget related, and it was what I think is the inaccurate perception that spending in North Carolina's Medicaid program was out of control. But that was the driver, and I think that's an important driver to remember as we move forward. The legislation required the integration of behavioral and physical health care. Managed care is required to go live 18 months after federal approval of a waiver. So one of the things about managed care is that when you make certain systemic changes to a state's Medicaid system, you have to get federal approval through a waiver process. And the timing of this is obviously unpredictable. And so that's why the timeline for this implementation is connected to the approval of that waiver. NCDHHS has a public goal of July of next year for launching managed care, although I think that's in doubt. I think it's going to get pushed back a little bit later, and we'll talk about some of those variables in just a moment. So again, apologies for the alphabet soup, but there's just no way around it. So here are a couple, so these are the 2 types of managed care organizations in North Carolina. First, overall, they're going to be called prepaid health plans. So if you hear the term PHP, just think of a managed care organization or prepaid health plan. That's what they are. And there are two types. There are going to be 3 statewide commercial plans, and then there's going to be a set of regional provider-led entities. And this model has not really been tried out in other states. So we're doing a little bit of experimentation here in North Carolina, and we'll have to see how it goes. So Michelle is reminding me to mention some examples of, the statewide commercial plans are going to be like, could be Aetna, Blue Cross Blue Shield, Centene. Many of them do this managed care work in other states. So that's just kind of who you're thinking about. The regional provider-led entities, it's a little bit more unclear exactly what those will look like. There are going to be 2 types of plans. So the vast majority of Medicaid recipients are going to enroll in a standard plan, and then there are going to be tailored plans. So tailored plans, according to DHHS, will be targeted to serve special populations with unique healthcare needs. So this is going to include a behavioral health and intellectual developmental disability plan. We also think it's going to include a plan for children in foster care, medically fragile children as well. And one of the details that's really still being worked out is exactly who's going to be in these tailored plans. So we'll get to that more in just a second. So this is a diagram of, make sure I didn't skip a slide. Okay, perfect. Of how Medicaid funding is going to flow in managed care in North Carolina. So as we mentioned earlier, it's a partnership between the federal government and North Carolina, and that money gets combined into the North Carolina Department of Health and Human Services, which then pulls it down to goes through 2 different paths. The vast majority of the money, once managed care is implemented, is going to go through these prepaid health plans. And again, there's 2 types: commercial plans, provider-led entities, and then they will contract with providers who will then provide the services. For a small subset of populations who are carved out of managed care, for instance, dental is not covered; it will not move into managed care yet. And then some populations will be phased in over time. They'll remain in a fee-for-service system where the Department of Health and Human Services will work directly with providers. Okay, so here is our timeline, basically starting right now and what we're looking at going forward. So when the legislature passed managed care, the authorizing legislation several years ago, it set certain guardrails for NCDHHS. And now NCDHHS wants to make some changes that aren't really within the bounds of those parameters that were initially set out. They want to do staggered implementation for different populations, and this concept of tailored plans is one that was not laid out in the initial managed care legislation. So the legislature and NCDHHS have to come to some agreement on this. Right now, there's disagreement within the legislature how this should look. There's disagreement between some factions of the legislature and NCDHHS what this should look like. Advocates have their own opinions, and so it's really up in the air exactly what the details will look like. But we're thinking the short session will be the time when this will be dealt with. And then, as I mentioned earlier, the federal government has to approve the waiver. I wrote May or June 2018 here. I have no idea if that's going to come true. I really think that the department has been saying that they're close to getting this approval, so I just do not know when that will happen. Oh, I apologize for folks if I'm going in and out. I'm going to try and get a closer connection here to the phone. So those 2 things have to happen prior to any sort of additional forward movement. The third piece of this is North Carolina DHHS releasing the RFP to potential PHPs for a contract. And if you don't know exactly what the populations are that are going to be in managed care, and if the federal government hasn't approved your waiver, you can't really do that. We think that DHHS is going to do this and release that RFP as soon as both numbers 1 and 2 on this list happen. So we're thinking sometime later this summer. And then there's going to be a process of negotiating and finalizing contracts and getting the PHPs to a place where they're ready to actually operationalize managed care. And that really could take a while. It looks like it's going to go live. Well, I don't even know. It will go live sometime in 2019, maybe 2020. That's my summer, fall 2019 is probably too specific, and chances are I'll get that wrong. And then, I did mention that some populations will be phased in over time. This is the DHHS plan for phasing those populations in over time. So you'll see that children in foster care and adoptive placements would be phased in 1 year after managed care implementation. Children and NC Health Choice beneficiaries with a serious mental illness, substance use disorder, or IDD diagnosis would be rolled in 2 years after managed care implementation. And then children in the CAP program would likely be rolled in 4 years after managed care implementation. So again, there is some time with the staggered roll-in plan, but that still needs to be approved by the General Assembly. Okay, so that was a very quick and brief overview of our transition into managed care, and I'm sure if someone from the Secretary's office heard it, they would probably be terrified by how quick it was, but we want to keep it at a pretty high level and keep moving forward. So now we're going to talk about protecting kids in the transition. So we are really focused on EPSDT as part of this transformation. As I said earlier, it is the core benefit for kids in Medicaid. It ensures they get the right services at the right time. And we know that there could be a substantial impact on EPSDT adherence in this transformation. We've seen it happen in other states where the MCOs are not able and willing to be able to make sure that children, that the EPSDT benefit is fulfilled for children. So one thing we know is that the managed care contracts really have to define medical necessity in a way that's consistent with EPSDT. And they have to specify whether the plan or state is responsible for different services, outreach, and data reporting. And so on that note, we are asking a variety of questions in Medicaid transformation. And we hope you will as well. So one is, where and how do RFPs and contracts with managed care organizations spell out EPSDT requirements? Up to this point, we haven't seen a lot of detail from HHS. HHS has been releasing concept papers quite frequently, which is a really good thing about various elements of managed care. And they're doing this to provide consumers and advocates and providers with more details about what managed care could look like in North Carolina. But what's been missing is this very specific details on EPSDT, and we really think that needs to happen. And we think it needs to also happen in the RFPs that are sent off to potential PHPs. In the contracts with these PHPs, it needs to be very specific about who's responsible for what. That includes not only the screening and the diagnostics and the treatment, it includes outreach and education for families. It includes provider engagement, data collection, public reports, consumer engagement and input, appeals and grievances processes. This is a really complicated issue. I've been working in this field for a good while now and still feel like I'm really just scratching the surface with all this. And for parents who don't do this for a living and are working, long hours and trying to care for their kids, there has to be a robust consumer engagement program to ensure that this benefit is the division of this benefit is actually fulfilled. And again, that goes to what is the input for key stakeholders, especially children and families and other consumers who are going to be using these plans. All right. Oh, before I move to that, I want to say one thing. So there are a group of advocates have been communicating with the Department of Health and Human Services about some of our concerns regarding EPSDT and have been urging them to do one of these concept papers on EPSDT. One thing we are going to provide with all the participants on this call afterwards is a draft email to send to the Department of Health and Human Services urging them to do a concept paper on EPSDT so we can see what their vision is for EPSDT in managed care. Okay, so I'm going to move on to just a few other things that I want to touch on. Again, as Michelle mentioned at the beginning of this call, this is really a high-level overview, and there are a lot of deep weeds to dive into on this, and we really chose to focus a little bit more on EPSDT on anything else. But I do want to talk about a few other issues that we're paying attention to. One is care coordination for women and for children and pregnant women. So one thing that North Carolina has done a very good job of doing with its Medicaid program through Community Care of North Carolina is establishing medical homes and care coordination for these two populations, which often need to have multiple providers to ensure that they're getting the right type of care, and to ensure that it's medical homes to ensure that it's coordinated. What we're concerned about is that in the transition to managed care, the infrastructure that has been built over the past several decades could be wiped out. And so that's something we're keeping an eye on. We're also extremely concerned about network adequacy and access. In North Carolina, in our rural areas of the state, there's already significant provider shortages, especially for pediatric specialists. And then also for OBGYNs and other types of providers. And so we're worried that the transition to managed care could worsen this problem depending on what the relationship is between various PHPs and providers are. If fewer providers start to take Medicaid because it's not good to work with the PHPs or in this managed care system, that could really worsen our problem. So we want to be very mindful of that. We're also extremely concerned about medically fragile children, many of whom are in the CAP program. Managed care, the purpose behind it is to really save money by incentivizing preventative care and upstream treatment. For many of the children who are medically fragile, this is really not possible. They have diseases that are expensive and that not necessarily going to get better with preventative care, and they're going to be expensive over time. And they have, the very expensive equipment and treatments and all of that. So our concern is that if the motive is to save money in managed care, the only way to do that with medically fragile children is to cut away needed services and equipment, and we don't want to see that happen. So that's a big concern. We're also looking at this tailored plan issue. We know it's not necessarily right for all kids to be in a tailored plan, so we want to have an ongoing conversation about that. There's significant controversy in that right now, as I mentioned, in the legislature and among advocates and within NCDHHS. So that's something we're going to be continuing to pay attention to, and also thinking about who's going to administer those plans. And then lastly, the speed of the transition is very important. So one thing that we've heard the department say and that we're encouraged by is that it's more important to get this right than to do it fast. And we wholeheartly agree with that we've got to do this right. We know if we do it fast, there's more likely to be all sorts of implementation errors. I think for many of you on this call, you've had experience with NC Fast, NC Tracks, and those rollouts were not smooth. And as a result, people did not get services that they needed. And if we do this wrong and do it too fast, we're worried the same type of thing could happen, and it could have a lasting impact. So that is a quick summary of our additional concerns, although there are more. I think we have a good bit, maybe 15 minutes for some Q&A, so we can do that right now. And I'm looking at Michelle, who's going to show me some questions. All right, the first question is, what does this mean for LME MCOs? Will they have to compete for the RFP? That is a great question, and the answer is it's unclear. As I mentioned, the legislature has to make some decisions about these tailored plans. One of the proposals that's been put out would allow the LME MCOs exclusive access to tailored plans over the first several years. After a certain time period passes, the LME MCOs would then be required to go through the bidding process like every other potential PHP. So the answer is unclear. It could be right from the start, LME MCOs might have to be bidders just like any other potential PHP, but we have to wait on that legislation to find the answer for that. All right, does our NC plan include Medicaid expansion with a work requirement? Would those adults also be part of the managed care plan? So the plan that the department put forward does include Medicaid expansion, and it does include a work requirement in Medicaid expansion. The legislature, however, would have to authorize Medicaid expansion before the department could implement it. And that doesn't appear likely this year. And Medicaid expansion is something we're certainly, as NC Child, we're very strongly in favor of because of the positive impact it has on families, both in terms of their overall health and finances. So that's where the status of expansion is. If the expansion was approved, all of those individuals would be part of managed care and would likely be subjected to a work requirement depending on any future legislation that would be passed regarding expansion. All right. Do you know if there are incentives built into the plan that will help the physical and behavioral health sides work together? Perhaps the sides will be eliminated. That's a great question. I actually don't know the answer to that. So I'm looking at Michelle to see if she has an answer for it. Here, I'm handing it over.
Hi, we're sharing a phone, sitting at my kitchen table. I think in North Carolina, what we are hoping for, obviously, is in the transformation to integrate, as you're noting, the physical and behavioral health sides, which, as everyone on the phone and every provider knows, are incredibly siloed and difficult for children and families to manage integrated care. And there's a lot of frustration around that. So the ideal is that you shouldn't be separating, the head from the body. And that whole health for children and families includes both of them together. That is the intent of the department. In terms of the specific incentives that are built into the department's both the waiver and the plan, we will have to get back to you on that and do a little homework. I also think that in the contracts with managed care agencies, how they are paying for and services, how they are envisioning their networks of providers, who those providers are, and the incentives that the MCOs themselves are putting forth for integration are going to be incredibly important. So I'm pinning this really good question, and we will go ahead and get the answer and get that out to people. Any other questions from folks? And I'm looking at chat, and I am looking at Q&A, and I don't see any more at the moment. So we'll wait one more minute and see if there's any other burning questions.
All right. Well, hearing none, I just want to go over a few next steps. So one is that, as I mentioned, we want everyone on this call who's willing to take action and email the department about putting together an EPSDT concept paper. We also encourage folks to join our Child Advocacy Network, and I'll include a link for the sign up in that. And within that Child Advocacy Network, we have a health working group. And so definitely if folks want to get to the weeds of Medicaid transformation and really want to advocate on it, please, we encourage you to join that as well. We also are considering doing follow-up webinars on Medicaid transformation. I think if we get feedback from this about specific topics people are interested in, we certainly want to include that. And then just one that we already do have scheduled. Dr. Betsy Tilson, the North Carolina Public Health Director, what's her title? State Health Director, that's right, is going to be doing a webinar in early June on purchasing health. And it's really going to be focused on social determinants of health and what we can do in managed care to drive social determinants of health. So it's an exciting opportunity that could be good. And we just got a question that actually is a perfect transition. So the question is, will PHPs work with community partners to address social determinants of health? And I think the vision for that is absolutely yes. I think it's going to take a while, and we're seeing some states other states do some experimental work around that. And Dr. Tilson's webinar is going to be a perfect venue for that discussion. And so we'll be sure to include information in that in our follow-up email. And then if folks have additional questions, please feel free to contact me. My email is rob@ncchild.org. You can also get up with Michelle at michelle@ncchild.org. And I'll go back to Michelle. And let's yes, we are going to share the slides, and we will also share the recording of this webinar too. So if folks want to live it all over again, they have that opportunity. But with that, I don't see any other questions. We are going to sign off. I appreciate all of you getting on the webinar today, and I hope everyone has a great rest of the week.